All right. I would like to thank Medtronics for sponsoring this session of Th1nk26 on surgical options, being presented by Dr. Matthew Mian. Dr. Matthew Mian is a neurosurgeon in Denver, Colorado with CarePoint Neurosurgery and Spine. He serves as the Director of Functional Neurosurgery at Swedish Medical Center. Dr. Mian grew up in Michigan and North Carolina. He earned his MD with honors from a joint program between Harvard Medical School and MIT, and then he completed residency in neurosurgery at Massachusetts General Hospital and a fellowship in functional neurosurgery at Emory University. Dr. Mian has practiced in Colorado since 2019. In his free time, he enjoys scuba diving, cycling, skiing, badly, he says, photography, and hiking. Now I am going to pass it over to Dr. Mian.
Thank you very much. Can you guys all hear me?
Yes.
Okay. So, what I wanted to do tonight is give an overview of, the state of the field of surgery for epilepsy in 2022. I've given versions of this talk the last few years. And, things, so we may have a cat or two that jumps in the middle, but things continue to change. And what I would say is I'm going to put a link up at the end. You can see it down here on the right corner, but my website describes a lot of these different procedures that you can read about offline in more depth. But why don't we jump in? I don't have any disclosures related to this evening. So a little bit about myself. I think Larissa covered a lot of that. So what I really wanted to do today is focus on three things. Just a bit of background on surgery for epilepsy. Who do we think about this for? Why do we think about surgery for epilepsy? Who is a candidate? Talk a little bit about some of the diagnostic tools that we use. In fact, surgical tools that we use to try to pin down a person's seizure type and where their seizures are starting from. And then we'll focus most of this evening on treatment options. What are the therapies that we currently have in 2022 that we can use for patients with epilepsy that's not responding to medications? Just by way of background, epilepsy, I don't need to tell you guys, is very common. 1 in 26 people, of course, in their lifetime at some point. And we know that about a third of patients with epilepsy, so somewhere around 30 to 40%, end up with seizures that can't be controlled with medications alone. And usually we refer to this kind of epilepsy as drug-resistant or medically refractory epilepsy. And we know from a variety of studies that we've done over the years that unfortunately, once somebody is drug resistant, the chance that adding a fourth, a fifth, a sixth medicine to their regimen will render them seizure free is very low. And that number has not really changed over the years. So this is a study that looked at the percent of patients that could not achieve seizure freedom. And you can see, despite 30 years of drug development, that number really hasn't budged. Still around a third of patients. So why does that matter? Anyone with epilepsy understands that having frequent or uncontrolled seizures can have a variety of impacts on life. So difficulty maintaining a job, a driver's license, changes in quality of life, changes in thinking and memory, and then, of course, a risk of sudden death, or what we call SUDEP, which is the catastrophic outcome of uncontrolled seizures that we're trying to avoid. So a strong motivation to treat patients who are what we call medically refractory. And this is the group of patients that traditionally we've considered epilepsy surgery for. To answer the question I often get, am I a candidate for surgery? I'd really say that surgery should be considered in any person who has seizures that have not been controlled after trying 2 or 3 medications. And that's actually a very large number of patients. Why do we do surgery? What are the benefits? Well, in some cases, surgery can be curative. It can eliminate seizures entirely. Even when it's not curative, however, it can change a person's quality of life, their ability to work, their ability to interact with their family. The technology we have today is improving rapidly. And surgeries available in 2022 are often much less invasive than what we had 5 or 10 years ago. So the message I want to really drive home this evening is that patients today have options. There's usually many different surgical options for a given person's epilepsy. And it's really a question of customizing that, choosing the option that is right for a patient and his or her family. I mentioned that there's a huge gap in the patients that are eligible for surgery versus those who receive actual surgical care. And there's a variety of reasons for that. Some of it is just familiarity of neurologists and patients with the surgical options that are out there. Some of it is fear or stigma of having surgery. And what we're trying to do with events like this is really just raise awareness about what those options are and kind of demystify them for patients and their family members. So what is the general strategy? How do we approach the possibility of surgery when I see a patient who has drug-resistant seizures? Really, the first goal is to try to identify the part of the brain that's causing the seizures. I like to make the analogy sometimes that seizures are kind of like wildfires that spread. So they start somewhere in the brain and then they begin to spread. And if they spread to the whole brain, that's what we might call a generalized tonic-clonic or a grand mal seizure. But often they don't spread to the entire brain. And as somebody who's trying to stop the next seizure, what I'm most interested in is where it's going to start, okay? So once we've determined where seizures are starting, the question that we ask is the tissue that is causing these seizures, is the brain tissue important for normal function that we don't want to disrupt? If it's not, then we may remove or burn that tissue with different techniques that I'll review later on. If it is important, or if there's more than one spot that's involved in the brain, we consider a different set of therapies that I'll separately discuss called neuromodulation to try to change the way the brain is behaving and its tendency to produce seizures. An important distinction I like to draw, and one of the first branch points in our decision-making about the type of surgery that might be considered, is the difference between partial onset, or what's sometimes called focal epilepsy, versus generalized epilepsy. So partial seizures, partial onset seizures are really seizures that conform to this analogy that I've just made. So something that starts in part of the brain and then spreads. Patients with generalized epilepsy, by contrast, have seizures that start basically all over the brain simultaneously. So there are different reasons that someone might have partial versus generalized epilepsy. Importantly, having generalized tonic-clonic seizures or grand mal seizures does not mean necessarily that a person has generalized epilepsy. Most adults have partial onset epilepsy, and most of the surgical tools that I'll review, with some exceptions, are for partial onset epilepsy. So this is kind of a diagram of how we approach patients with seizures. After confirming that somebody has seizures that are resistant to drugs, the first question, as I mentioned, is trying to localize those seizures to a particular part of the brain. Where are they starting? How do we do that? Well, that involves a lot of the testing that patients may be familiar with. So the first thing is really simple. It's very basically the seizures that occur at the start of a seizure. Excuse me, the symptoms that occur at the start of a seizure. So the symptoms that you experience when a seizure starts usually reflect the part of the brain where the abnormal electrical activity is happening. We add on this with something called a video EEG, which you can do either in a brief outpatient setting or in the hospital over several days. This is basically an electrical study of the brain with electrodes glued to the scalp. We'll often do imaging of the brain, including a brain MRI and a PET scan, and that helps us look for structural abnormalities that might be a source for seizures. And then finally, something called neuropsychological testing, which is detailed pencil and paper cognitive testing that helps us home in on areas of the brain that might not be working as well as other parts of the brain. And each of these gives us an independent clue about where seizures are starting. Sometimes we have situations like this where all of those pieces of information point to the same culprit. And sometimes we have this kind of situation where, an MRI might suggest one area, an EEG might suggest another, and we're left at an impasse. And so in this circumstance, we consider additional testing that I might perform in conjunction with a neurologist. And that's really what I want to focus on next. So diagnostic tools. What do we do beyond a regular scalp EEG to try to figure out where in the brain seizures are starting? Sometimes we call this phase 2 monitoring. And in principle, this is very similar to a regular EEG that's done. But in this case, the electrodes are not on the scalp, not on the skin, but actually on the surface of the brain or inside it. And the reason for doing this is just that it gives us much more detailed information about seizures. So, this is a cadaver slice looking at the brain. Just imagine these blue discs represent scalp electrodes that are on the surface. One of the most common places for seizures to start is in the temporal lobe and for example, in the hippocampus. That's really far away from the skin. And so you can imagine that these electrodes on the skin have a hard time reading what's going on at a brain structure that's often, 5, 6, 8 centimeters away. So to get around that limitation, we have several forms of phase 2 monitoring. We'll go over each of these. The most common and popular today in 2022 is something called stereotactic EEG or SEEG. And this is a technique where we put in tiny wires, they're less than a millimeter thick, directly through the skull and into the parts of the brain that we think are responsible for seizures. This technique was actually invented a long time ago in France. And I thought this old black and white photo was kind of funny. It's very French. The patient is actually smoking a cigarette during the monitoring, but things look very different today. We do this now using 3D planning software and a surgical robot that allows us to introduce these electrodes with very, very good accuracy to the point where a SEEG implant might look something like this. So just tiny little holes that are a couple of millimeters wide where we insert these electrodes and then have the patient in the hospital for several days, for a week, as we wait for seizures to happen. This is a video showing a 3D reconstruction of one of my patients that had one of these implants, so you can see kind of what these electrodes look like. So there are a number of wires here, and each wire has 10 little metal contacts along it that sample different spots in the brain. And the value of SEEG is that it teaches us how to customize surgery for individual patients. We learn about different types of seizures that a patient could be having, and we can learn on a millimeter spatial scale where they're starting in the brain. So some advantages of this technique: it's very effective at localizing seizures. If you look at big studies, about 95% of patients can have their seizures pinpointed. These incisions are very tiny, and so this is a minimally invasive procedure. It's very flexible, it's accurate, and it's compatible with some of the treatment options that we'll discuss momentarily. An alternative to SEEG that we sometimes use is something called foramen ovale electrodes, or FO electrodes. And these are similar to SEEG, except they're used exclusively for studying seizures that we think are happening in part of the temporal lobe. They're also pretty non-invasive. They're just inserted one on each side through a pinpoint incision in the cheek, just with a needle. And they enter through the base of the skull in this little hole that's highlighted in green, and it's called the foramen ovale. This is that hole highlighted with a yellow arrow that I can see on an X-ray. I use X-rays to put these in. And you can see the two ends of the wires here inside the skull, and they end up right on the medial side of the temporal lobe, right there. The third technique that we have for diagnosis, for pinpointing these seizures, is something called cortical grids. These are basically pieces of silicone that have little tiny metal electrodes on them, and they sit not inside the brain, but right against the surface of the brain. This is something we've had for a long time, for decades, and we had before SEEG, and is still used in some circumstances, but has mostly been replaced by SEEG, because these typically take a bigger opening in the head to insert, as opposed to the tiny openings that I showed you before. So once we gather information with these diagnostic tools, what are the treatment options that we have for patients with seizures? And I should say that not all patients with drug-resistant epilepsy need those diagnostic tools that I showed you before. Those are options that we use in some cases, but certainly not everybody needs them. So we use these tools or other tools that we have, the semiology, the EEG, the MRI, and once we've pinpointed a location in the brain, the question that we usually start with first is this part of the brain resectable? In other words, is this the part of the brain that can be removed or damaged or burned without causing a problem to the patient? And we have different ways of doing that, of testing that. We know that, for example, areas that correspond to vision or movement or memory, generally we don't like to remove because we leave the patient with problems. But if the area of the brain is what we call resectable, we might consider something like a craniotomy, which is the traditional way that we've approached removing epileptic tissue. And the most common way that that's been done historically is with something called a temporal lobectomy. These are images of a temporal lobectomy, which is where we take out the front part of the temporal lobe. You can see a defect here on the scan, as well as here, for patients that have seizures originating from the front part of the temporal lobe. It's a surgery we've had for decades and decades, and we know it's effective, but we've discovered more recently that there are probably less invasive ways to do this just as effectively. One of the ways that we're using a lot now that's been popularized is something called laser interstitial thermal therapy, or LIT, or sometimes we refer to this as laser ablation. This is a minimally invasive technique in which we introduce a tiny little laser fiber. This is what it looks like. It's just a couple millimeters wide, into a part of the brain, and then heat up that brain tissue using a laser that's at the tip of this tiny little fiber. We can do that in an MRI scanner. So the patient is asleep, the patient is under anesthesia. This is an image from the platform we use to deliver that therapy. This little black line is the laser catheter. And in the MRI, we can actually monitor the temperature changes in the tissue and predict when we've irreversibly damaged tissue. In other words, when we've eliminated the tissue that we think is responsible for the seizures. We can then take the fiber out, and there's just a tiny little opening that we close with a single stitch. And this procedure has really emerged as an appealing alternative to the temporal lobectomy that I showed you before. And in particular, we insert the laser fiber from the back of the head with the goal of damaging usually the hippocampus, which is the most common site in the temporal lobe for seizures, as well as other parts of the temporal lobe, including the amygdala. So this is a video from one of my patients. And what you'll see as I turn it on is the laser fiber, and you'll see little orange blobs develop around the tip of the fiber. Those represent the areas that have been burned by the laser. And so this is a nice procedure. As I mentioned, we don't have to make a big opening on the head. It's just a tiny little incision that really doesn't even require shaving much hair at all. And patients are usually able to go home the following day. This is an example case. This is a man I saw a couple years ago who'd had epilepsy for decades, and his seizures consisted of an episode of déjà vu. He would often stare off into the distance, pick at his clothing, and be confused for several minutes. He had what's called mesial temporal sclerosis. So his hippocampus here is bright on his MRI. It doesn't show as much metabolism on his PET scan. And his EEG indeed confirmed that he had seizures arising from that side. And so we performed a laser ablation. You can see the little zone where the ablation happened there on the MRI, and it's right here on the other scan. And this patient did very well. He was on 4 seizure medicines, and he has been seizure-free since the procedure, has been able to come off of all his medicines. And unsurprisingly, this has made a big difference in this patient's life. A little bit about benefits and drawbacks of this technique. As I mentioned, it involves a fairly minimally invasive approach, a tiny incision, a short hospital stay. And we've discovered that it generally leads to better cognitive outcomes than a full temporal lobectomy. The drawback is very simply that if you compare this to a temporal lobectomy, the rate of seizure freedom is slightly lower, 5 to 8% lower. It's not suited as much for lesions in the brain that are large. The laser is very pinpoint. We have to focus it on a very particular area, and so it requires us to be able to target that area. But for patients who are eligible for this, it's a very nice technique. So what happens if the part of the brain that we're looking at that we think is responsible for seizures is not resectable? In other words, it's an area of the brain that we think is important. Maybe it affects movement or vision or language. Or maybe there's more than one area in the brain that we don't want to remove. What options do we have in that circumstance? So the 3 techniques that we have available in 2022, and I'll go through each of these in turn, are vagus nerve stimulation, or what we sometimes call VNS, responsive neurostimulation, or RNS. Sometimes this is known by the trade name of the device, which is NeuroPace. And finally, deep brain stimulation, or DBS. And these therapies collectively are referred to as neuromodulation. That's a big word. That's a big word. What does that mean? Neuromodulation is, at a basic level, it's just applying electrical stimulation to the nervous system. In this case, to the brain or to nerves connected to the brain, with the goal of changing the way the seizure network behaves in the brain. So this is seldom a cure. So most patients will not be completely seizure-free with one of these therapies, but patients generally see very significant reductions in their seizures, and they also enjoy other benefits. So study after study have confirmed that patients have improved quality of life. They have good cognitive outcomes versus if we had taken out part of the brain. And importantly, for all of these procedures, patients have a reduced risk of sudden death from epilepsy or SUDEP. These therapies are flexible, they're reversible, they can be taken out if needed. In general, they tend to grow more effective over time. So that means that a patient who has this surgery is usually doing better at 6 months than they are at 3 months. They're doing better at 12 months than they are at 6 months, and so on. There's something about the nervous system that changes over time when we apply these therapies, and it usually translates into better and better seizure control over time. So to go through those one by one, vagus nerve stimulation, or VNS, is the one that we've had for the longest. I think this is an outdated slide. There's been, hundreds of thousands of patients treated since this was introduced 25 years ago. It works really for all seizure types, and it's the only procedure of those we'll discuss today that's outpatient, meaning you don't have a hospital stay, and it does not involve a procedure on the brain, unlike these other procedures. Instead, it involves implanting a thin little wire, as you can see illustrated here, on a nerve called the vagus nerve that lives in the neck and basically travels from the brain down to the viscera in the body. This is what the device looks like. So as you can see, the battery nowadays is pretty small. This is a quarter for size comparison. And this is an operative view from one of my cases showing what this looks like. This is a small incision on the front of the neck, and I've dissected down, and the vagus nerve, it's kind of hard to appreciate here, is this kind of white strip that I highlighted that lives between the carotid artery and the jugular vein. And so we wrap a tiny little coil around this and send the wire just a little bit down to the chest under the collarbone, where we put in this little battery that acts like a pacemaker. VNS can work in 3 different ways. So one is that it delivers a pulse of electricity to that nerve every few minutes, what we call continuous therapy. There's also something called auto stim. So the generator, the little battery, is constantly listening to the heart rate. And if it sees that the heart rate has picked up very quickly, very suddenly, that's something that we know precedes seizures in many patients. It can give the patient an extra dose of therapy automatically. And finally, this device also comes with a little wrist magnet that you wear on your wrist, and you can wave over the device either the patient or a family member to give an extra dose of therapy if the patient or family member sees that a seizure is about to come or is happening. And just like the other forms of neuromodulation, we think that VNS becomes more effective over time. My usual rule of thumb to patients when I see them is that about the average patient sees something like a 50% reduction in seizures over time. And as I mentioned, we also have studies that show that VNS improves quality of life. That's what QOL is, and also reduces the risk of sudden death. So the second device we have for neuromodulation or for electrical treatment of seizures is something called responsive neurostimulation, or RNS, or again, it's often referred to by the trade name, which is NeuroPace. In other words, a pacemaker for the brain. This was approved now almost 10 years ago for focal epilepsy. And we use it as a nice option when the tissue in the brain that we think is causing the seizures is not really amenable to one of the treatments I mentioned before, to craniotomy or to the laser treatment. And the way the device works is that it's a tiny little microprocessor, a little computer that we embed in the skull. It has 2 wires coming from it that go into the brain, and they constantly listen to the brain for seizure activity. This thing is running in the background 24/7, kind of like an EEG that you have for life. And anytime the device, the computer, sees an event that it thinks is concerning for a seizure, it gives the brain a little zap of therapy. And so a patient may get hundreds or thousands of these per day and not realize it. We program this so that patients can't feel the zaps. But what this translates to is fewer and fewer seizures over time. So this is kind of an illustration. You can imagine this is the electrical activity in the brain bouncing up and down. Something starts to happen that is heralding the start of a seizure. So the waves start bouncing up and down even more. The RNS device recognizes this, delivers a pulse of energy, and the brain waves come back to normal. At least that's the idea. This is an example of what the implant looks like. Again, this is a reconstructed CT scan from one of my patients. You can see the pulse generator embedded in the skull. It's not sitting on top of the skull. It's actually replacing a small piece of the skull. And then we have these 2 wires that are coming into the brain. In this case, these are also targeting the hippocampus, the structure I mentioned before. So again, this is entirely inside the body. It's not visible from the outside. And this device is constantly working in the background, trying to determine if the brain is having a seizure. Just like with VNS, the studies we have of RNS suggest that the therapy becomes more effective over time. And interestingly, RNS seems to work all over the brain, regardless where we put it. And something that I often show patients, a lot of patients that I see are struggling with memory after they've had seizures for years and years. Interestingly, many measures of cognitive performance actually improve with RNS. So as we treat these seizures, as we stimulate the brain, something is helping patients' cognition and memory. We don't really understand this effect. And interestingly, this seems to happen even when the seizures aren't reduced dramatically. So stimulation is doing something to the brain that seems to be beneficial for language, for learning, for memory. And importantly, RNS provides very nice feedback to patients' neurologists. So neurologists are able to look at the readout of the device and understand objectively how many seizures or little blips are happening in a patient's brain over time. I think it can be really tough for some patients to recognize when they're having seizures. Sometimes patients don't even recognize a seizure. Sometimes a family member doesn't recognize a seizure. Some seizures during sleep might be hard to see. But the nice thing about the RNS device is that it's constantly listening, and it tries to provide an objective measure of seizure frequency. And so a neurologist, for example, can start a new medicine with the patient and actually observe whether that medicine is effective or not, whether it's reducing seizures. And so this is a nice tool for helping guide therapy in the office for patients with this device. So the final therapy I wanted to talk about is something called deep brain stimulation, or DBS. This is the newest addition of those I've discussed to our armamentarium. But this is in fact a treatment that we've had for 20 years or more, that we've used to treat other neurologic disorders, things like Parkinson's disease and tremor, but was approved back in 2018 for treating patients with epilepsy. It's similar in principle to RNS, so there's little wires that enter the brain. You can see them superimposed on this MRI here. And these wires target a very precise location that we think is an important node in the circuit that causes seizures in many patients. Once again, here's a 3D CT reconstruction of what DBS looks like, and next to it is the DBS battery. So the electrode comes in usually from the top of the head and then aims towards this area that we call the anterior nucleus of the thalamus, or ANT. This little red dot that I've shown here, or the blue dot here. And importantly, this target is the same from patient to patient. So we don't have to customize it based on where a patient's seizures are starting. And just as with the other therapies, we see that seizure control seems to improve over time. So the average patient long-term sees something like a 75% reduction in seizures, and a not insubstantial number of patients in this series, about 18%, had seizure-free intervals, so no seizures for at least 6 months at a time or more. Just as some of these other therapies I mentioned do, DBS tends to reduce the severity of seizures for patients, and importantly, these patients in big studies that have looked at this report a better quality of life. And just like RNS, it seems that some measures of cognitive performance actually get better in patients that have had DBS. Again, we don't understand the mechanism of this, but it appears that there's something about stimulating the brain that tends to help with cognition. So, this is what our surgical approach to epilepsy looked like, say 10 years ago. And what I've hoped to leave you with this evening is that the options we have today are considerably wider. Usually when I meet a patient in the office, there are several of these options that we discuss at length and entertain. But I really try to customize the surgery to what a patient's goals are, what their overall health is, and what their family situation is. So this is usually a long discussion. A question I often get is, what about patients with generalized epilepsy? Do we have nothing for them? And the answer is no. We have actually several options for them. It turns out that the 3 methods of neuromodulation we spoke about, so VNS, RNS, and DBS, in the right context, can all be options for patients with generalized epilepsy. But importantly, these are therapies that we call off-label. So what does that mean? It means simply that we use them for these disorders. We think that in many cases they are effective for these disorders, but the companies that manufacture these devices generally haven't paid for big clinical trials to look at patients with generalized epilepsy. So it's kind of a gray area. The FDA allows us to implant these devices, and doctors, as doctors, we can make our best medical judgment for patients. I mean, there are many medications currently that are used commonly that are off-label. But this really requires a careful discussion with the surgeon. I'll highlight one of these that's a little bit newer that we've started to do more, and that's what's called thalamic RNS. So using the NeuroPace device in a deep part of the brain called the thalamus. And we've seen really exciting data from a number of studies across the country that this holds promise for patients with generalized epilepsy. And in fact, we've done several of these implants in my practice at Swedish already. So, this is the message I want to leave patients. My seizures are not controlled. Is surgery right for me? Where should I start? This is a common question that I'm posed at events like this and in the office. The first thing I would say is have a discussion with your neurologist. Ask about surgery. Ask whether that's something your neurologist is familiar with, whether they think it's a good idea. If you are seeing a neurologist that's maybe not as familiar with some of these options, I think it's sometimes worth a discussion with a more specialized neurologist called an epileptologist. This is a doctor who specializes in the treatment of seizures and is generally familiar with a lot of the things that we're discussing this evening. And then finally, sometimes it helps to be your own advocate. I see a lot of patients who come to me not through their neurologist, but because they're advocating for themselves and they want to learn more about surgical options. And certainly I welcome, as do other surgeons, visits from patients who are curious as to whether there's a surgical option for them. So with that, I'll wrap up and leave some time for questions. Again, I'm going to highlight the website I've listed down here in the bottom right. This is my personal website that I maintain that has pages on epilepsy and all of the different surgeries that we discussed this evening, along with some images and I think even a few videos. But with that, I'll wrap up and thank you guys for your attention.